Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McCray.
Frozen shoulder. It's also known as adhesive capsulitis, and it's a fairly common problem. Frozen, in this case, refers to the fact that the shoulder is fixed or stiff. You can't move it, and it's almost always painful. It happens.
I just was wondering, I wonder if everybody that hears the term frozen shoulder just starts moving their shoulders. I've been trying very carefully. Just
see if it's cold.
Yep,
it's
just
not a cold
keep it
shoulder.
still.
Well, it happens when the sac or the lining or what we call the capsule that holds the shoulder joint in place tightens up due to inflammation, and that restricts the joint's movement.
Signs and symptoms typically begin gradually, worsen over time, and then resolve, but it takes time and treatment. It may take a year for your shoulder function to return. Here to discuss is Mayo Clinic orthopedic surgeon Dr. Christopher Camp. Welcome back to the program, Dr. Camp. It's good to see you.
Thank you, guys. Thanks so much for having me. It's an honor.
Dr. Camp, nice to have you here.
Thank you.
Frozen shoulder, it's an interesting problem. And how common is it really? How often do you see it in your clinic?
Very common, actually. And it's difficult, too, to diagnose sometimes because it overlaps with a lot of different shoulder problems that tend to occur in the same demographic. So most commonly occurs in people in their 40s, 50s, 60s. Most commonly occurs in females. But that's also the same demographic that also starts to get shoulder arthritis, rotator cuff tears, all of which have some similar symptoms. So we see it commonly, and then we have to work pretty hard to sort of sort out what exactly the problem is and what our treatment's going to be, because it varies depending on the diagnosis.
Can you usually determine a cause for it?
No, usually we cannot, and that's one of the tough things about it. We know a lot about it. We know the different stages. We know how long it takes to get better. We know how to treat it. We think we have an idea of what causes it, but we don't know for sure. We know that it starts by an inflammatory process, so something happens within that joint capsule that you were describing. It gets really inflamed, painful, starts to thicken up, and then the shoulder gets really stiff.
You think you know what causes it? What is that?
Yeah, so we know that injuries increase the risk. So, and it can be a minor injury, just a small little tweak to the shoulder, and maybe something really subtle, and patients really didn't think much about it. And then over the course of the next few weeks, it happens. We know that it can happen after shoulder surgery. So if you've had surgery in the shoulder, there's more inflammation after surgery. So that places a patient at increased risk for developing as well. And then we also know there are a few risk factors. So folks with diabetes and thyroid problems tend to be at higher risk for getting it, and it can be tougher to treat in those patient populations as well. So
thyroid problems, that's sort of interesting. And being female, is you're more likely to get it?
Well, I just want to know, what's the difference between when you have a really tight shoulder and maybe a couple of knots in there, and it gets so it feels like you can't move it around. I suspect that is not frozen shoulder, even though it kind of feels like it.
You're correct. Yeah, exactly. And so frozen shoulder really refers to the glenohumeral joint, which is the ball and socket joint. That's the main joint of the shoulder. So it's the lining around that. So it's a very specific term describing a specific area. People commonly get tightness around the shoulder or knots in the muscles. That's a little bit of a different thing. So it has to be focal to right at the joint, the ball and socket joint, in order to be frozen shoulder.
And how do you nail down the diagnosis? You said it can sometimes be difficult based on history, exam, both, imaging?
All of the above. And really the hallmark is, obviously the main sign and symptom is pain and decreased motion, so an inability to move the shoulder. And typically patients will come in and say, I can't lift my arm up. And then I try to lift it, and I can't lift their arm up either.
Really?
So if they can't do it and I can't do it, that usually signals frozen shoulder, which is different than a rotator cuff or a muscle problem. If they can't lift it because of their own muscle, usually if I take the shoulder, then I can lift it for them. But in frozen shoulder, neither one of us can lift it. So that's kind of the hallmark of the diagnosis.
And that's always the case? It cannot be moved?
Correct. And that's sort of the nature of it. It can't be moved by the patient or anyone else who's trying to do it.
Well, then that seems like it'd be easy to diagnose if that shoulder does not move.
It does, but all of these problems exist on a spectrum. And so some are extremely easy, some are a little bit difficult. And the problem is sometimes they can occur with rotator cuff tears or with arthritis. So you have to sort out which symptoms are coming from which problem.
You said women, thyroid issues, diabetes. Are there other people who are at risk of developing it? Did we cover them all?
Those are the main ones, and then folks that have recently had an injury or
right.
surgery.
And what about, does imaging help you at all, or just to rule out other things?
It mostly helps to rule out other things. There are some signs that we can look for on an MRI. It'll show that the capsule or the joint lining is really thickened, and that's very classic. However, we don't typically get it. We don't typically get an MRI for frozen shoulder if it's pretty clear that that's what's going on based on the patient's symptoms and our examination. Don't always need that.
So how do you treat it?
Great question. So it exists in 3 phases, and so it depends on which phase we catch the patient in. So the first phase is the inflammatory phase, which is very painful. So that's when the capsule starts to get inflamed, it gets thickened, and the patients are having a lot of pain. If we catch it in that first phase, we typically will start with a steroid injection, a cortisone or a corticosteroid injection into the joint, and then that sort of goes in and it bathes or soaks the capsule and hopefully decreases the inflammation, which will decrease the pain and improve the motion.
Is that a painful procedure?
It can be. It requires a needle stick, but it is at least quick. So maybe slightly painful, but quick. Most patients really tolerate well without much sedation or pain medication.
You're already in quite a bit of pain, so probably doesn't matter.
Relatively speaking, it's not too bad.
All right.
Exactly. And that would be phase 1 or stage 1 disease.
Exactly. And then that's followed up with physical therapy. And physical therapy is really the mainstay of treatment. You just have to keep working at it and stretching it. And then if we catch patients in the second phase, which is the stiffening phase, so that's usually the inflammation is done, so they're not having a lot of pain, but the shoulder's very stiff, the injection's not quite as helpful in that second phase, and it's really just physical therapy and just stretching. And it's a pretty deliberate daily routine of stretching. And so the good news is that treatment is sufficient for the vast, vast majority of patients. So 80 to 90% of patients will have complete resolution of their symptoms and never have a problem again. That's the good news.
So you teach them a therapy program that they can do at home, and
Correct.
if they're religious about doing it, they can ultimately get most of their motion back?
The vast majority do. The vast majority will have it completely go away. The bad news, though, is that it usually takes 6 to 12 months. So we talk a lot about patience and endurance and resilience. So you have to stick with it, and it takes a little while, but it almost always goes away. 80 to 90% of patients get full motion back, no pain, and do really well. They just got to hang in there.
And what about the outlier, that 10% that don't seem to respond to those 2 modalities?
Right. So if you don't do that and you're continuing to have symptoms for 6 months or so, then surgery is an option. Surgery is a very successful and greater than 90%, almost 100% success rate, pretty close to it. And that's typically an arthroscopic procedure. So it's minimally invasive, done through small little incisions where we go in and we release the capsule all the way around the joint. So we go ahead and do that work for you. So we release everything and stretch the shoulder out.
Under anesthesia.
Under anesthesia while the patient's
asleep. So you're doing this through the small scope, the
exactly.
telescope.
Yep. All done through the arthroscope or the telescope, and then patients they start physical therapy after that. So that's sort of a way for us to kind of help jumpstart them and sort of put them 2 feet in front of the finish line. So that'll help speed things up for them and help them get a lot closer.
And that's about 10% of patients who don't get better with an injection and physical therapy?
Correct.
So that's pretty good. And even if they don't respond to those 2 modalities, you're 100% effective pretty much in the surgical option.
Pretty close. It's in the upper 90%. So for the unfortunate few who do go to surgery, the good news is almost all of those will have resolution of their symptoms with surgery.
If the reason why you have a frozen shoulder is not due to injury, if it's one of the others that we spoke about, are you likely to get it in the other shoulder as well?
Yeah, great question. So typically, no. Odds are in your favor there. Only about 20% of patients actually end up getting it in the other shoulder. However, as we mentioned, if you have diabetes or a thyroid problem, you may be slightly higher, somewhere in the 30 to 40% range. But for most people, only about a 20% chance that it happens on the other side.
All right, one last question. Why the shoulder? I mean, because you never hear about a frozen hip or a frozen knee.
Yeah, it's a great question. And we don't know for certain, but it could be that the shoulder has such a large capsule that goes all the way around the joint. It's a very shallow joint that has a lot of motion to it, so the capsule gets stretched in the shoulder, probably more so than any other joint. So it may be just prone to irritation because of the amount of motion that it has to go through.
Is there any way to prevent it?
Unfortunately not.
All right, frozen shoulder. Everything you wanted to know from a Mayo Clinic orthopedic surgeon, Dr. Christopher Camp. Dr. Camp, thanks so much for being with us.
Thank you so much for having me. Really enjoyed it.